Good day, friends, and a warm welcome to the first episode of Session 2 of 4D, that is Details, Discussion, and Dialogue in Indian Diabetes. We had a very successful first season, and now we are back. We are back with more enthusiasm, more energy. There are so many challenges that we face in our country regarding diabetes care. So many, actually, that they are difficult to enumerate. But where there are challenges, there are solutions. And to overcome these challenges, you need someone who has broad shoulders, strong shoulders, someone who has experience, someone who has knowledge, and someone who is willing to share this with us. For this, allow me to welcome one of the most successful, one of the most well-known diabetologists of Pune city of Maharashtra. Warm welcome, Dr. Suhas Irande.
Thank you, Dr. Sanjay Kalra. Uh, I have already declared myself as one of your fans in the capacity of illustrious editor of IJEM and world-renowned prolific academician. Uh, Thank you so much for your kind introduction.
Thank you, sir, for these kind words. And actually, all of us, physicians from across India, we are your fans and we are just waiting to listen to you, to learn from your wisdom and your experience.
Sir.
Our topic for today is cardiovascular disease and diabetes, and both these work in tandem. But, sir, feel free to share whatever you wish to with us. We are all united in our aim, in our ambition to have uh, a complication free India, an India that is free of diabetes complications. So, sir, the stage is yours.
Thank you, sir. Thank you so much. Nice to see you and nice to be here.
Sir, in our OPDs, when patients come to us, we have a lot of discussion with them. There's a lot of dialogue as well. They ask many questions and they want to know things in detail. It's their right also. People have a right to know what's going on. And
Yes, sir.
one of the questions that they ask is, Doctor, will diabetes harm my heart? And will diabetes medication harm my heart? How did you answer this question 25 years ago and how do you answer it now, sir?
Yeah, absolutely. 25 years ago, we definitely knew that diabetes certainly has a proclivity to create complications, not only through the high sugars or low sugars, but by their bad effects on the different organs. And we already had the UKPDA study, DCCT study, which told us that good glycemic control certainly can retard or delay the complications, the retinopathy, neuropathy, or the nephropathy, and even the heart attacks or the strokes.
Mhm.
So we knew. Now, after 25 years, we probably know it better. We want to steer clear of hypoglycemia because if we do too much of treatment, more stringency, we can create complications rather than reduce them. And we have better modalities of not only monitoring, not the urine glucose or the venous glucose, but glucometers, the continuous glucose monitors, the gadgets which can work in tandem with each other and maybe mimic the delivery of insulin just like the human pancreas, and of course better pharmaceutical agents which can not only treat the high glucoses but avoid low sugars and also protect the kidney, heart, and the different organs. So our answers and probably our stance certainly has become definitely different, more robust, more science based, and more practically useful for the patients.
Thank you, sir, for sharing this optimism with us. We have better diagnostics, we have better therapeutics also now. And even though heart disease and diabetes are partners in crime, they work together to create havoc in the human body. Even in spite of that, we are able to use these diagnostics and these therapeutics now in a way that we can protect our kidney's heart and now our patient's heart. And today we can actually tell our patients that we have medications which not only are safe but are also of benefit to your kidneys, to your heart. We are able to help you improve the quality of your life and also the quantity of your life by giving you these heart friendly medications. Sir, would you like to share more about this cardiovascular disease and diabetes, what's going on in the space of this field, and how we can upgrade ourselves? Would you like to share anything with us, sir?
Yes, sir. Thank you so much, sir. And welcome, friends. I will be talking about multifaceted challenges in managing diabetes in Indian patients. We know very well that diabetes as the Lancet editorial has mentioned here, will be a defining disease of this particular century. And we already know that the diabetes worldwide epidemic is already threatening lot of uh, countries, even our own country, not only with the health adversaries, but with some financial strains and loads on the health budgets as well. Our primary drivers for our country, there are many, but the chief ones could be listed as something which is sedentary lifestyle, which is related to demographics. Also add rapid urbanization and industrialization to that. Then the environment, which is technically called as obesogenic environment. And then we have some kind of genetic explanations. I will allude to some brief in my presentation. So Southeast Asian phenotype is peculiar. And then our diets certainly have changed very rapidly. And rather than being healthy diets, they have become uh, carb rich, refined carb rich, fat rich, saturated fat rich, and maybe unhealthy for the metabolism. So, genetics, our own Professor Yadnik, who is my teacher since my medical college days, has taught us very famously that the Indian phenotype is more centrally obese or viscerally obese. The fat percentage of an Indian phenotype or an Indian person, for example, Professor Yadnik and Professor John Yudkin from UK, both are similar body mass indices. However, Professor Yadnik and Indian phenotype had a higher fat percentage compared to Professor Yudkin, and the fat mass is chiefly in the viscera or center. So, excessive accumulation of adipose tissue for a given BMI, excess central fat, and lesser peripheral fat can certainly pose more of insulin resistance. And then Professor Mohan had discussed about Asian Indian phenotype, which actually is having a lot of features, chiefly the low birth weight, thin fat Indian, and when exposed to the fuel or nutrition plenty in his adolescent and future life, he can get metabolically decompensated and become a diabetic. And it is characterized by a lot of other features like increased NAFLD or MASLD as per the new terms, increased abdominal obesity, increased inflammatory markers, low muscle mass or sarcopenia, and low vitamin B12, vitamin D, differences in the gut microbiota, low adiponectin levels, rapid decline in the beta cell mass, low serum insulin levels, insulin resistance, and lower threshold for the body mass index to develop diabetes. And then one more recent study by Professor Mohan, Dr. R.M. Anjana, and their group, they have found that we have chiefly in our country, we have chiefly four phenotypes of diabetes, type 2 diabetes. One is the severe insulin deficient diabetes, around a quarter of the people. Then another is called as IROD, insulin resistance obese diabetes. Next is the combined insulin resistance and deficient diabetes, which is the most difficult to control, as Professor Mohan told us, and the mild age related diabetes, which is around a third, 35.8%. Why this is important to understand is, for example, the same group of researchers, they have found that depending on which phenotype you have, for example, this is SIDD, severe insulin deficiency diabetes, then the risk of retinopathy is, the hazard ratio is 1.56. The CIROD, combined insulin resistance and deficiency diabetes, the hazard ratio is 1.31. Nephropathy, again, the SIDD and CIRDD phenotypes, they have a higher risk of developing nephropathy, chronic kidney disease, and diabetic kidney disease. So that's always better, and we can plan the therapy if we know it better. This is just an analogy from the cardiovascular people, and they have focused on multiple population level changes, like, for example, epidemiological, demographic, environmental, socio-cultural, nutritional, and economic. And on the biological risk side, early life influences and inherent biological or genetic differences, which I have briefly alluded to in our Professor Yadnik's teaching. And this is what Professor Yadnik's teachings are: the fetal origins of adult disease, the fetal programming, genetic and epigenetic changes, early life determinants resulting into intermediate phenotypes with metabolic abnormalities down the line, these people could not only have diabetes but central obesity, higher cardiovascular disease risk, and mortality. So this is the background which we discuss in India. We have different problems like the shades of epidemiology, pathophysiology. We have different healthcare delivery models and challenges at the physician level, at patient perspectives, different health beliefs, and socio-cultural challenges. This is a very recent study called as ICMR in-depth study, again published by Professor Mohan and his group of researchers. Generally, it has been found that the number of diabetics in India is projected to be 10.1 crores, pre-diabetics 13.6 crores. More importantly, more than half of these, they don't know that they have diabetes or pre-diabetes. So this is more dangerous. This is a boiling pot for future complications. And these are the country maps, different prevalences of different problems. For example, abdominal obesity, which is a very important problem in our country. We can see here that the prevalence is very high, more than 25% in large number of states in our country. And these are the different features which Professor Mohan has displayed here. One is, of course, the first is diabetes, the next is the pre-diabetes, then dysglycemia, hypertension, then generalized obesity and abdominal obesity. You can see here that hypertension and abdominal obesity are the most prevalent problems in ICMR in-depth study. And then the hypertriglyceridemia or high HDL, which are of course going to be cardiovascular disease risk factors. So that's what ICMR in-depth is. Now going to the Ministry of Health and Family Welfare. As you know, they conduct periodic National Family Health Survey called as NFHS. This is the most recent one which they have published, and they looked at very important parameters called as ACT: awareness, control, and treatment. So, what was their observation is amongst those with diabetic, 27.5% were aware, A, 21.5% were taking treatment, so T, and 7% had their diabetes under control. So that's what is the ATC. And more importantly, if you look at the graph, the histogram, these are the different states of our nation, and it has been observed that at least one in three households carries one patient of diabetes. So the extent to which diabetes has percolated is extensive, and it is across the length and breadth of our country. And these are the prevalence, awareness, treatment, and control graphs. If you can see the prevalence and the awareness, okay, the prevalence is high in most of the states, awareness is low in most of the states. The treatment is all right, somewhere in between, but the control is poor, generally 7%. That's what actually has been observed in the National Family Health Survey. Looking at the, let's say, some other issues, for and I have quoted here some of our national and international stalwarts. For example, Professor Mohan again and Professor Shashank Joshi, they had published their article in JAPI, the Association of Physicians Journal, in 2008. Challenges in diabetes care in India: sheer numbers, lack of awareness, and inadequate control. So, Professor Joshi here has alluded to complications like retinopathy, like nephropathy, and especially coronary artery disease, which was again a very important feature of the cure study which Professor Mohan did from Madras. And it was observed that the coronary artery disease prevalence can be anywhere between 17 to as high as 21% in the urban people who have diabetes. So that's something which is important. Are there any particular reasons apart from the genetics and epigenetics? Well, the demography is rapidly changing. As I told you, we are industrializing and urbanizing very rapidly, and the result probably is the decreasing number of active adults. It has come down from 31.9 to only 20 over a span of hardly 5 years, as you can see here. And that is something which has probably, sedentary lifestyle has increased, and that's probably has increased the number of diabetic patients by threefold. Then adherence to modification measures, like for example, dietary discipline, like for example, activity, increasing physical exercise, watching the weight, reducing the simple carbs, reducing the refined carbs, doing away with saturated fats, bakery products, etc. In different studies, observational studies, for example, Diabecare India 2011, 6,168 type 2 diabetic studies. only 54.6% patients were compliant to the dietary advice, and only 37.2% patients followed the exercise advice. So that's something which is a very challenging situation for us. Now the environment increased, the rapid urbanization I have already alluded to, 5 times increase in the finances. So GDP growth is certainly rapid, and that disposable income is probably making people more of the slaves of the machineries. So remote controls and elevators and different kinds of automobiles and washing machines and so many things. So people are moving less, getting stuck to the screens, either the computer or the televisions or the cell phones, and that's why the physical activity is reducing. There is a 17% increase in the number of supermarkets, which is again an interesting observation, and that has certainly resulted in consumption of ready-to-made meals, and which contain high preservatives, maybe high content of sodium, and maybe refined carbs, saturated fats, trans fats, etc. And you can see here that the McDonald's, which is a famous chain, they uh, started their first outlet in 1968, but by the time we are talking, their number of restaurants has gone up to more than 350. So that's probably the big change. Diet is a big change, and per capita energy consumption also has rapidly gone up from 2055 in 1975 to 2549 as of the recent observations. And the increase in the per capita consumption of bakery products like cookies, crackers, and others, they have also gone up. The confectionery or the ultra processed foods has gone up. And then we also have some kind of a, you can say, WhatsApp university, and we have different kinds of so-called experts which tell us different things about diet, what to eat, what not to eat. But the basic misunderstandings about the glycemic indices, some foodstuffs are unnecessarily cleared as safe and advantageous, but they may not be. So that is something which is our area to rectify. So these are the challenges. The family environment of the dinners, that has certainly changed from the open air to the restaurants, and probably the saturated fats and the refined carbs, that number has gone up. So from the government side, this is a Lancet article, and they have actually scrutinized a lot of things. They have said that India has tried to address the critical policy gap of introducing the guidelines for prevention of misleading advertisement and endorsements for misleading advertisements. That was 2022. And this policy chiefly is to, you can say, curtail the television and the other media advertising, which are directed chiefly towards the children and adolescents, and they may fall prey to the different ultra processed foods or to some unhealthy food items. So that's something which is a matter on the government side, and we have to certainly coax the government to implement these. So the health implications for these dietary and other changes, nutrition transition, sedentary lifestyle, we have gone rapidly up. The non-communicable diseases, they have gone up by more than 2 times, diabetes more than 2 times, hypertension more than 5 times, obesity more than 10 times. And mind you, this has happened only in the last 2 decades. So that's a very fast transition. And maybe some amount of transcultural diversity in our country also can be a big challenge. India boasts of rich and very varied kind of cuisine, and we certainly have good attachment to that social identity, religions, cultural factors, agricultural practices, availability of diverse foods, which of course has now become very easy. You can order an item from South India right in Delhi or Dr. Sanjay Kalra's Karnal, maybe very easily, and you will get a very hot dosa and idli maybe within a couple of hours also. So 41 dietary patterns are identified in India, and maybe assessing and making them more healthy can be a big challenge. This is just a feature to as a final comment on the dietary challenges. North India probably fat heavy, South India carb heavy, West India again fat heavy, and East India probably carb heavy. This is a general comment. And the STAR study, again by Professor Shashank Doshi, has told us that more than 65% of our calories from the daily intake, they are attributable to carbohydrates, and most of them could be simple carbs rather than complex carbs. Looking at the control level of diabetes and some other parameters. For example, the average HbA1c of our country is something around 2% higher than 7%. Various studies, some have 8.6, some have 9.3, but generally we are around 2% above the target, that is 7%. So 9% is the average HbA1c of India. And even on therapy, only 16% of people can be called as good control. Some studies, for example, our own landmark study, which got published very recently, we also found that most of our people, maybe 17 to 27% of people, more in the metropolitan areas rather than in the non-metropolitan areas, we saw that that is the level of percentage which the patient can have HbA1c of 7%. Most of the others are still uncontrolled. And mind you, this is at a relatively earlier type 2 diabetes onset. Our onset is around 40 years of age rather than 50 plus in the Western population. We have, as I told you, higher insulin resistance, combined insulin resistance and insulin deficiency. And these problems can be certainly challenging for the treatment of diabetes. Looking at the different studies themselves, for example, Diabcare Asia, CODI study, Dedicom study, of course, these are not very recent, but still, these studies also were not looking at the holistic or the wholesome issues. Like, for example, every study has not really looked at HbA1c, mean HbA1c, blood pressure control, lipid control, etc. So we have to have studies which look and assess the situation more in depth rather than maybe otherwise. Then this is something which is looking at two different kinds of doctors. One is the government sector and the other is the private sector. And the essence of this busy slide is that the government as well as the private doctors, a large percentage of these doctors, they don't go into the nitty gritty of diabetes. They don't go into the fasting PP sugar assessment, HbA1c assessment, urinary albumin creatinine ratio, EGFR, lipid profile, foot examination, retina examination, etc. So that is something which is certainly needed. And Professor Vijay Vishwanathan and Professor V. Narayan, they have summarized some of the important findings of problems in diabetes care in India. Developing countries like India face a huge burden of diabetes and its complications, and they have suggested lot of measures. For example, appropriate monitoring and follow-up, proper access to healthcare, financial burden needs to be curtailed and managed properly, presence of economic disparities need to be sealed, non-adherence to recommendation guidelines by us, that is doctors, also has to be reduced. And most importantly, Professor Vijay Vishwanathan has told us that the anti-diabetic drugs monitoring, other drugs like, for example, antihypertensive, statins, antiplatelet drug, etc., the disposable, the insulin needles, etc., or the pump disposable, doctor visits, that's something which is, you can say, totally that can be something like two-thirds, but the largest contribution to the expenses is attributable to hospitalization, more than 35%. And it is very obvious that it is the diabetes complications which make the patient get hospitalized, and the expenses certainly are going very high. And the urban rural divide, again, here you can see here that whether you are in an urban area or in the rural area, zero complication, the expenditure is relatively less. One complication, the expenditure shoots up, and two complications, the expenditure shoots to practically more than, let's say, 28,000. So that, and this study, mind you, is more than a decade old. So you can imagine complications, if we avoid, we certainly help the patient better. This is a presentation in ISA-EM, and of course, Dr. Sanjay Kalra is one of the authors of this. This is something which is looking at insulin treatment, not the general treatment of diabetes, but they have pointed to the very important aspects of addressing the convenience and lifestyle of the patient, convincing the patient about the safety of the drugs. May not be only insulin, but maybe GLP-1 analogs, maybe drugs like SGLT2 inhibitors. We have to explain sulfonylurea, we have to explain the risks, etc. And we have to educate the patient. So that these 3 points, which are mentioned here, the lead author is Professor Subhash Wangnu from New Delhi, and the other prestigious endocrinologists, including Professor Sanjay Kalra, they have given a lot of clues to solutions of diabetes care in India. One of our more, you can say, other professor, for example, this is Dr. Ashok Kumar Das, our respected professor from Pondicherry. He has looked at the healthcare delivery models in India and relevance to diabetes care for us. So they have identified barriers, for example, low awareness and diagnosis of diabetes in our country, 50% people in ICMR indirect study, they don't know that they have diabetes or pre-diabetes. Lack of diagnosis and access to quality care because of the wide geographies of India. Medication adherence and patient issues certainly remain important. Time constraints on the part of the physician and suboptimal knowledge among physicians. We have to really take care of that. And lack of trained diabetes educators and the paraphernalia or the other staff is something which is again important. They have suggested some measures for effective management, like, for example, strengthening the healthcare systems, affordable technology use, healthcare governance for creation of guidelines and provision of funds, education and training of the general practitioners. Maybe I will add to the physicians also, and to the experts. We have to keep on, you can say, revising and updating ourselves. Public and private partnership, the windows of opportunities. For example, gestational diabetes is a very good window of opportunity, not only to prevent the future diabetes for that particular index lady, but for the fetus which is born of that GDM, and the transgenerational progression or dissemination of diabetes can certainly be prevented by these measures. We can certainly take care of some of the global, let's say, thought processes, like, for example, Lancet Commission on Diabetes, using data to transform diabetes care and patient lives. Then we can certainly look at some other methodologies. For example, this is a WHO STEPS data, and these are pertaining to South and Southeast Asia. And they look at the age, gender, and education of the person, and then metabolic risk factors like hypertension, diabetes, central obesity, overall obesity, total cholesterol, and then behavioral risk factors like smoking, alcohol intake, insufficient fruit and vegetable intake, low physical activity, etc. These are certainly, if we reach the situations, we can certainly collect that data and maybe modify future deterioration of the problems, maybe put them into such kind of a one risk factor, two risk factors, three risk factors, etc., and maybe judge the risk and manage the patients accordingly. Similarly, Professor Sujay Ghosh from West Bengal, he has actually been a lead author of this particular article. They had looked at the metabolic unhealthiness and looking particularly at the risk of non-alcoholic fatty liver disease in India. We can also, as metabolic physicians, certainly take, you can say, some messages out of such studies. So, my friends, multifaceted challenges, and we need multiple solutions. So increase health awareness in the population, increase mass screening for non-communicable diseases and of course diabetes, increase the physicians NCD education, novel strategies to implement lifestyle modification, stringency for complication screening, evaluation, and of course management, rigor in the attaining of HbA1c, blood pressure, cholesterol, and of course the DEFG, etc. control, use of technology effectively for mass education, improving awareness, and maybe healthcare delivery also, and of course continued surveillance on all these situations. By I end up my talking with this very famous uh, Julian Tudor Hart's paper. This was published more than 50 years ago in Lancet, 1971. The essence of it is the availability of good medical care tends to vary with the need for it in the population served. This inverse care law operates more completely where the medical care is most exposed to market forces and less so where the exposure is reduced. Indirectly, the most needy people get the least of help from the healthcare authorities, and the, you can say, least needing people, they get more health attention from the authorities. So that's what is the situation, one of the challenges in our country. I thank you so much for your kind attention. And before ending, this is one, you can say, slide which probably tells us that effective newer modalities of drugs, like for example incretin drugs, the DPP4 inhibitors and the GLP-1 receptor agonist, and the gliflozins, SGLT2 inhibitors, certainly have proved their meritocracy in randomized control trials, not only for good glycemic efficacy and HbA1c control, but helpful for systolic blood pressure control, helpful for lipids, and most importantly, a very important cardio-renal protection, reduction of weight, reduction of the waist circumference, relative risk reduction of heart failure hospitalization. And we can certainly bank on a fact that incretins work a shade better in Asian Indian individuals compared to the Caucasians and Western population. Similarly, gliflozins also work better in our populations. We can certainly make use of combination therapies of DPP4 inhibitors and SGLT2 inhibitors to give our patient oral, effective, accessible, appropriate kind of management for diabetes. I thank you so much for your kind attention.
Thank you, Dr. Suhas. And you very beautifully covered the entire spectrum of diabetes care. And I think there's a lot of insight in it, lots of things for us to chew upon to understand. At the same time, a lot of inspiration for Indian doctors. And
Thank you so much.
when we speak about detailed discussion and dialogue, I think this is what we want. We want inspiration, and we want someone to push us so that we can work together to improve diabetes care in the country. Sir, a few questions coming your way.
Yes, sir.
The first question is about aspirin. What was the status of aspirin in diabetes care, maybe a decade or two earlier, and what is the status now? What do you practice in your OPD?
Yes, yes. In fact, I can immediately allude to just couple of days back, the JAC Asia journal has published, you can say, the distinctive use of aspirin for diabetic patient, primary prevention. And they have compared the situation in the Asian patients versus the Western patients. And they have found that yes, aspirin certainly is useful, a shade probably better than the Western populations in our situations. We appreciate that the diabetic platelets are probably a bit, let's say, tough as far as the deaggregation action of aspirin is concerned. But aspirin certainly is something which is an important tenet as an antiplatelet agent for addressing the cardiovascular disease in diabetes.
So, sir, do you prescribe aspirin now to every adult with diabetes or to just a select subset of them?
I right now I strictly adhere the to the
Guidelines.
RSHDI guidelines and to the ADA guidelines, which are generally popularly followed. With the latest AHA meeting, which happened just a couple of weeks ago, and their new methodologies, they have devised something which is a newer risk scale estimation for different populations, and that is beyond race, and that also specifically for diabetes they not only look at diagnosis of diabetes yes or no, but it is type 1 or type 2, duration of diabetes, control status of diabetes, everything is factored into that scale. And I believe that if we use that scale, will be probably and with the cutoff of maybe 10 or 15% of risk, we will be probably using aspirin to more number of diabetics than maybe the bland assumption that okay, if the age of the patient is less than 30, for the race phenomenon we will not use it, or ASCVD risk calculator, which actually is tilted more, let's say, favorably for the young patient, their risk comes as low. And here in the latest AHA risk scale or risk measurement, the risk is 30 years, so not 10 years. So that's something which probably I will use, and maybe aspirin I will be using in more number of patients.
Sir, one more question. This has come from many physicians across the country. We now have many FDCs available, fixed dose combinations available in the country.
Sir,
There is
sir,
the dapagliflozin plus sitagliptin combination. So, two or three questions regarding this. The
yes, sir.
first is, uh, are they rational partners? Is it a rational combination, dapagliflozin plus sitagliptin?
Okay, arguing for the class. So DPP4 inhibitor, representative sitagliptin, and sodium glucose co-transporter inhibitor, representative dapagliflozin. Pharmacologically, both are acting for 24 hours. All right. Two, are the actions, pharmacological actions, or the mode of action on the diabetes, are they complementary to each other? Most certainly, because AGLT2 inhibitor has a very specific role in the proximal convoluted tubule. The overexpressed AGLT2 receptors, they will be suppressed. Glycosuria, natriuresis, aquauresis, so on and so forth, and thereby alleviation of hyperglycemia. Beta cell, no business to deal with. Then DPP4 inhibitor, the correction of the reduced half-life of the glucagon-like polypeptide 1 by inhibition of the dipeptidyl peptidase 4 enzyme, GLP in its own peculiar way, stimulating the GLP receptor on the beta cell membrane, acting to secrete insulin in a glucose-dependent manner, also having action on alpha cell, suppressing the postprandial unabated hyperglucogonemia. If the ambient glucose is low, then the same alpha cell will be made to produce more of glucagon. So avoiding hypoglycemia. In fact, the incretins are the ones which for a CGM person like me are the best, because they not only curb the hyperglycemia time above range, but they also reduce the risk of time below range or hypoglycemia. So SGLT2 inhibitor, different mechanism of action. DPP4 inhibitor, different mechanism of action. In a way, the GLP also may be not true with the DPP4 inhibitor, the gliptin, but with the GLP-1 injectables, supraphysiologic levels of GLP can certainly modulate the appetite in such a way that the weight can be reduced. Some amount of gastric emptying time is delayed, so the postprandial sugar also is favorably influenced. And the important point, DPP4 and SGLT2 inhibitor given together, we address most of the Professor Ralph D. Fronzo's famous octet of pathophysiology of type 2 diabetes. So incretin defect is sealed, SGLT overexpression is sealed, some amount of insulin resistance from the skeletal myocyte, hepatocyte, and the adipocyte is curtailed. There is a subtle stimulation of the beta cell, though not like a secretagogue, but still a subtle stimulation of beta cell. So the secretory defect also is addressed. And this comes to around maybe 6 to 7 out of the 8 pathophysiological defects of type 2 diabetes. So we address not only hyperglycemia, but we address it more on a pathophysiological base. So probably the progression of the disease also can be expected to be halted. And of course, the hyperglucogonemia induced by the SGLT2 inhibitors will be curbed or at least checked by the gliptins. So the side effect, which is likely euglycemic ketoacidosis, that also is negated. Another important thing, the glycosuria and the genital urinary mycotic infection risk also is reduced by, and has been shown by a lot of famous professors. Professor Julio Rosenstock easily comes to my mind. They have shown that combined use or ABDC use of these drugs, certainly the genital urinary mycotic infection comes down, and which is a very important issue as far as treating physicians like me and all of them are concerned. So, from all points of view, sitagliptin, a gliptin, and dapagliflozin, a SGLT2 inhibitor, their co-use certainly is beneficial medically, pharmacologically, pathophysiologically.
Sir, a very nice comment coming, and this is from a doctor in New Delhi who says that he visited Pune earlier, and this combination reminds him of the famous food of Pune, the misal pav. So the misal pav is two foods which you can take together, and they make each other tastier. So that is how
Absolutely.
giving
Very
dapa
nice
and
analogy. Very nice
yeah.
analogy. Yeah.
So he says this is the misal pav of FDCs in diabetes care. But I'm curious to know, sir, when we use this misal pav FDC, that is DAPA plus sitagliptin, what other drugs can I use it with? Can I use it with metformin? Can I use it with metformin plus sulfonylurea? How much of freedom, how much of flexibility do I have?
Yeah. Uh, I distinctly remember the since 2014, the two triple combinations were very frequently discussed in EAHD. One was empagliflozin, then linagliptin and metformin, and the other was saxagliptin, dapagliflozin, and metformin. So either on the background of metformin, a combo of gliptin, gliflozin, or all three together. And this was something which was supposed to be a really holistic kind of addressal of the pathophysiology. The important point automatically comes as in India, we are always using metformin as the first uh, pharmacotherapeutic agent for type 2 diabetes, unless contraindicated or not tolerated. But we are using it, and then we are sequentially adding or maybe adding the combo of gliptin and gliflozin together, especially if the A1C is at 1.5% above the target recommended. That is something. So I can certainly use metformin with a combo of Sita and DAPA. That's number one. Number two, whether should I use maybe other drug like we have AGSI, we have pioglitazone, we have lobeglitazone. Can we use them? Well, yes, if I again quote Professor Ralph D. Fronzo, the most favorite combination he says of his amongst the orals is on the background of metformin and empagliflozin and a pioglitazone. And pioglitazone certainly has been, you can say, given a fairly high weightage even by the latest ESC guidelines. So we can use these drugs. because they will not only give you different mechanisms of action for glycemic control, and they will give you better vascular protection, pertaining especially to pioglitazone. The fluid retaining tendency and the risk of heart failure, which goes up with pioglitazone, is negated if DAPA is already on board. So, well, I can use metformin, I can use pioglitazone. Now, sulfonylurea, that's a very interesting proposal, really speaking. It's very difficult to really comment as a, you can say, clinician on this situation, because as I have already mentioned, the GLP-1 or the DPP-4 itself, by improving the GLP, they are also secretagogues in a strictest sense of pharmacology. But for us, because they act in a glucose dependent manner, there is a very negligible risk of hypoglycemia. Talk of sulfonylurea, the classical stimulatory or secretagogue of the drugs. Then we have two secretagogues, one from the SUR1 receptor and the other through the GLP receptor. So that is something which is a technically speaking, same beta cell will be stimulated by two different mechanisms. Now, Sanjay sir, I actually feel that this is one, you can say, limit beyond which I can't comprehend whether they should be used together. That's something which I will say here. We are using, because metformin, sulfonylurea already on board in a maybe 10 year ago, and then we added a gliptin, and then we, though there are three drugs, we just to avoid or prolong the insulinization, we added a fourth drug which was maybe a gliflozin. So in a same prescription, we have sulfonylureas and we maybe gliptin and gliflozin together. But should they be given in the same tablet? I feel that I will request you to take the call.
Well, I personally do use sulfonylurea and gliptins together. So maybe a drug like dapagliflozin plus sitagliptin FDC, and along with another FDC of metformin plus sulfonylurea. It is not sustainable for a long period of time. But along with that prescription, so when you read the prescription, whether it is mine or anybody else's, you see that this is what has been written from a drug point of view. What you do not see is the counseling that is going on behind the scenes. And the counseling is that, yes, now you're on four drugs: DAPA,
Right.
CETA, metformin, and SU. Uh, we may be able to help you for a short period of time, but not for a long period of time. So let's get you on insulin. Let's begin preparing you. This is the
Right.
background conversation that is going on. And
Yeah.
if it is going on together, then there's no harm. If there is no immediate life threatening, no immediate organ or limb threatening complication, then you can prescribe four drugs. But keep a close watch, be very vigilant, and get your patient on board.
Absolutely. Absolutely. Yes.
Sir, one last question for you, and
Sir.
this comes from another food lover, and he says these days our diabetes prescriptions look like the Bahubali thali that we get in Pune when we go to eat food. Bahubali thali means lots and lots of prescriptions all around. So, what role have FDCs played in sort of making the Bahubali thali a bit more palatable and a bit easier to eat?
Yes, sir. Actually, sir, I would like to resort to your own, you can say, editorial and more publications in IJEM. And I distinctly remember the words you had used, that those were the days when the glibenclamide and sulfonylurea combination was brought into Indian market. And you had written at that time that through the other disciplines, like, for example, the Ayurvedics and others, India is already very proficient as far as the combination of different drugs is concerned. That's what you had alluded to. And you had also alluded to the combination of different antihypertensive drugs. The popular one at that time was nifedipine and atenolol. And the others, like, for example, anti-tubercular drugs or antibiotics. You had alluded to all those. And sulfonylurea, glibenclamide, and metformin, they were brought for the first time in those days prior to 2000. And well, yes, two three things certainly come, you can say, to come to the mind. Number one is just like the sita and dapa which we discussed, the pharmacology or the mechanism of action for the purpose of diabetes control certainly is served better by attacking more different ways of controlling the sugar, just like the nifedipine, the calcium channel blocker, and atenolol, a beta blocker. They control hypertension and they negate the tachycardia of nifedipine by atenolol. So they have to have some synergies and some additive effects or multiplicative effects if possible when they are combined. That is one. Number two, of course, the pill burden comes down, the cost of production comes down, so becomes pocket friendly, easy for the healthcare giver also. So some family member, if he is administering tablets, then it's very easy to administer once a day or twice a day and forget about it. No multiple tablets. Very importantly, sometimes, for example, glibenclamide typically should be given prior to the meal. It's a sulfonylurea. Metformin typically pharmacology says that you should give after the meal. So some kind of cutting corners does happen. However, in practice and in the long run, that may really not matter, because if the patient takes the drug, then is going to be an expectation of a better control and maybe attaining the targets, protecting the organs, etc. So combinations certainly very good. There is no question about it.
With this, sir, I'd like to thank you. You have mentioned all the challenges in your talk. You talked about the challenges, the barriers that we face to good diabetes care in India. But then you've also talked about the solutions, about the
So,
bridges that we can build with our patients. And the good thing is that we have all these advances in therapeutics. We have newer classes of drugs like SGLT2 inhibitors, and we have newer FDCs, which make it much easier for us to share the best of science with our patients and to ensure that they achieve the best of control. With this, sir, I'd like to thank you once again for having come on 4D. That's detailed discussion and dialogue in Indian diabetes. Thank
sure,
you,
sir.
sir, for all the hard work that
Thank you
you've
so
put
much,
into
sir. Thank you. You are very gracious as always. Thank you so much. And thank you, all my friends who are there. Thank you so much.
Thank you, everyone. Looking forward to a healthier, a happier